My name is Luis Valdez. I'm the Spanish Ezra Council. So I want to say you welcome to this venue. You will see we have a really fantastic place. We have you'll have 12 cadavers. They are TL cadavers, so we can scan these cadavers. They are flexible. They are much similar than fresh cadaver than another formalin cadaver. So we'll have really expert. You have expert profession in each issue. So take you can have a really fantastic course during all the days. There are 8 stations, so we have to rotate every station. This is quite important to be on time because we are 14. You are 40 delegates, so it can be a bit complex if you don't go fast changing to each station. Okay, we have a small lecture. Free of going there. I'm going to talk about ultrasound approach for clavicle fracture. I have no disclosure on this topic. I live here. I'm from Spain. I live in the south of Spain. This is Marbella. It's close to Gibraltar Strait. This is my hospital and Hospital Costa del Sol. Some of you are wondering why this want to talk about clavicle fracture, because we know that the classical treatment was orthopedic, you can see here. But in last year, this is from 3.5 years ago, we know that it has been an increase in clavicular surgery, much more than could expect with the incidence, the increase of incidence. Why? Because there are new techniques, especially for distal fracture, and the results literature show that maybe results are better with the surgery. So it's quite a new surgery, and it's a big challenge because we don't have almost knowledge of the innovation. There's just only two treatments for many cases, like 7 cases. There is no scientific evidence, so that makes several strategies, and I'm going to show you a special one we have been working on. Listen to this video, please. Start working. Yeah, always this problem. Sorry. Okay. I don't know what's happening. It was a video, was an surgery under sedation, and as you can see at the end of the surgery, the patient can move. There is no lateral plexus block. So, but I will speak about clavicular fractures, the innervation, what do we know about the innervation, and which kind of strategies we can use. Clavicular fractures, they are 30% of all shoulder fractures. This is important. Close 80% medial segment or mid shaft, close 20% distal, and it's very strange medial fracture. That's important because the innervation change along the clavicle, so you have to plan different strategies. It's also important to know what the surgeon is going to do. Is not the same a plate, an anterior superior plate, and a plate with an anchor system to coracoid, or a plate with a hook under the acromion for really distal and acromioclavicular. So it depends on the surgery, your strategy will be different. About innervation, we don't know clavicle innervation. It's a quite strange bone, but we have to consider dermatomal and osteotomal innervation. Dermatomal is clear. We know that the dermatomal innervation, all the skin above the clavicle is superficial cervical plexus. It's supraclavicular nerve. This nerve, it's a main nerve, emerge below the sternocleidomastoid muscle, and it's divided in three branches. But maybe just only cutaneous innervation. There are some data that's only patients or communication, and some anatomical data maybe can give more innervation than skin, but we don't know exactly about that. If we're looking for stomal innervation, our classic text that works because they are confounding also. Sometimes they are opposed. The information you can find in classical text. So we have to look for studies of anatomical dissection of shoulder innervation, and this is really important. Histological works focusing the study of how the bone is innervated. About these studies of anatomical dissection, there are several studies really interesting, but they only give us information of distal clavicle. And in the distal clavicle, there are two important branches. Is the articular branch of suprascapular nerve, that's main giving innervation of the posterior aspect of acromioclavicular joint, and the articular branch of lateral pectoral nerve that give innervation to coracoid, that's important, coracoclavicular on coracoacromial ligaments, and the anterior aspect of acromioclavicular joint. Okay, but the rest of the clavicle, we don't know about this innervation. All this innervation, we don't know nothing about that. So, if we take a look to these histological works that look for innervation of bone, they tell us that main bone innervation is not only, but main bone innervation depends on periosteum. And in periosteum, there are a lot of small fiber nerves entering the periosteum and comes from adjacent muscles. So, this periosteum is particularly rich innervated in the set where the ligaments, tendon, capsular joints, and muscle are inserted in the periosteum. So we know that all muscles that are inserted or has origin in the clavicle will give any kind of innervation to the clavicle. So if we take this dermatoma cutaneous, what we know of anatomical, the distal clavicle, and what we know about these histological works, we can check all of them, and maybe, this is a proposal, this is my proposal, so it's not demonstrated, so I'm sure I'm not really wrong, but there are a lot of nerves involved in the innervation of the clavicle. The problem of that is it seems too complex to perform selective nerve blocks, so you have to focus in metameric block from C4, C5, and C6. Okay, that's true, but so in if we base in that, we can we use several strategies. I have make a comparison between total knee arthroplasty and this clavicular fracture. You know, techniques has moved from central to a more distal or peripheral blocks, so we can do something similar. These are classic block from we can equate neuraxial to cervical. I don't recommend this. To lumbar plexus block to interscalene block, main branches of lumbar plexus to supraclavicular brachial plexus blocks plus cervical superficial plexus blocks. This has been maybe the classic approaches. The problem, you know, always you have risk or you will block your diaphragm, no? Because phrenic block. So what will you do in that case? This is we have strange patient in my hospital, so we can see also this. It's not so. You cannot do that, and always remember that in between 25% of clavicular fractures, they have perioperative nerve lesions. So if you are performing a brachial plexus block, maybe it can have consequences in these lesions. So there are a really interesting article published less than 2 years ago, 1.5 years ago. It's PEX2 modified. This is the largest series published, 7 patients. It's from Spain, South Lives. It's maybe the main author here. They adapted PEX2 modified, make a combined anesthesia with a laryngeal mass, and they refer it's good postoperative pain control with minimum morphine. They perform from lateral to medial, perform an injection between pectoral major and minor, and another below pectoral minor to block medial pectoral nerve. But they fall. They don't give an anatomical explanation of how this work block extract the implication of the lateral pectoral nerves in the innervation. Okay, so I've been working in another more distal block, this clavipectoral fascia plane block. This is, let me show just a bit of anatomy. This clavipectoral fascia this is strong sheet. It's attached in almost all about the clavicle. It's connected with this is the coracoclavicular ligament, calcaneus ligament, and also with the axillary suspensory ligament forming the roof of the axilla. It encloses the pectoralis minor muscle, and that's really important. Enclosed pectoralis minor, but it's connected with subclavius fascia is connected with this is pectoral superficial fascia, and with the investing layer of deep cervical fascia. So they form envelope, like an envelope of all the clavicle. So you can see when in the surgery, the surgeon, they open this clavipectoral fascia, open the periosteum, and reach the clavicle, put the plate, and after close the clavipectoral fascia. So if our histological works tell us that all muscle inserted or origin in the clavicle give innervation, and you have this clavipectoral surrounding all the clavicle. So the question the idea was, why not to inject below this clavipectoral fascia and look what's happened. So this is the idea. Go there, inject, and then will be a space containing that. So what we do was look for a healthy volunteer. In this healthy volunteer, we perform, and this was a bilateral supraclavicular nerve block, and when the skin was anesthetized, after that we perform in the right one injection at the middle level of clavicle with lidocaine and gadolinium as a distal fracture, considering it was a distal clavicle fracture, and in the left one proximal and one distal injection, considering there was an mid-shaft fracture. So these are the image. You can see how it's surrounding the clavicle is much important in the left one and the two injection side. You can see here this is a coronal view, how it's spreading the spread there of the image. I have too light, so it's not really good. I can see here fantastic, but not here. Here you can see the connection with the pectoral superficial fascia and the investing layer of deep cervical fascia, and how it's surrounding all. In a sagittal view, you can see this spread and how is this is the clavicle is, I can see it's here. Sorry, but the image is not good here. This is marking, this is brachial plexus. Only this brachial plexus is absolutely free of the dye, the solution. You can see here this clavicle more distal, how it's completely surrounding all the clavicle. Okay, and this is the volunteer. It's me, and they were really happy to inject me. It did some injection, no brachial plexus and no Frenny block, I promise you. Okay. Well, I was working with Mario, and then we performed a cadaveric study. In this cadaveric study, as you can see, we're going to open here the clavipectoral fascia. We inject here just only one injection, 20 mils, and two injections, 10 and 10 mils, red and blue. We dissect here cervical plexus was the main idea, and here clavipectoral fascia. When you open, sorry, I don't know what's happened with the videos. They're not working. Sorry. Let me check. Yesterday it works perfectly. Okay, when you open, you can see the dye was under the subclavius muscle and was connected with the investing layer going proximal and also distal with the superficial pectoral layer going above the pectoralis major muscle until the humerus insertion, humeral insertion. So the techniques, sorry, I don't know if the videos are going to work. You have to place your probe in a sagittal paramedial plane, and one is you have to rotate, just to orientate cauda, trying to achieve, I don't know if it's working, sorry, yeah, you have to do that, just to put this is the upper surface, I know what's, sorry. Okay, you can see parallel to the probe, the clavicular surface, the anterior border and posterior border. Then you have to inject from cauda to cephalad. You have here the needle. You have to enter the needle until you contact the periosteum, the bone. You have to contact the bone. When you contact, you start injection, you will see one first line, this is periosteum, and when you have inject maybe 2 mils, you can see here, it's periosteum. When you inject 2 mils, you will visualize a second line that correspond to the clavipectoral fascia. So videos, yeah, this line here. So you have to place your needle here and then make the injection. And now injecting between 15 and 20 mils. Sorry for the, yeah. You redirect and then you inject there. It's important when you perform the injection, you will see cephalad and cauda spread of the local anesthetic. If you don't visualize this cephalad and cauda, sorry, if you don't visualize that, you have to remove your tip of the needle, maybe cephalad or cauda, to achieve adequate spread in one on other. Okay, about clinical cases, we have performed 24 blocks, mid-shaft 20% and distal third 4%. We perform a supraclavicular nerve block with a low volume, 2 to 4 mils bupivacaine 0.25. After 5 minutes, where the patient refers skin is analgesia, has analgesia and CPP block, 2 injections, proximal distal to the fracture in mid-shaft, and with between 10 and 20 mils. Now maybe 15, 20 mils in each injection. And it depends if the surgeon needs an iliac crest graft bone extraction. It depends on the surgeon. Some they perform local infiltration, or we perform an QLB type 2. Okay, with our primary objective was, analgesia. Analgesia was descetoprofen and paracetamol every 8 hours, and rescue analgesia, tramadol or morphine. Primary outcome was pain at recovery room, prior going to the ward, and at 24 hours. And secondary outcome, consume of intraoperative fentanyl, first opioid rescue in the first 24 hours, and any clinical evidence of brachial plexus or flank nerve block. So for these mid-shaft fractures, 20, there were mostly male, John, this is median age, weight, healthy, and 12 were general anesthesia and the laryngeal mask, 6 with endotracheal tube, and 2 patients under conscious sedation. Our intraoperative fentanyl was really low, 1.8 per kilogram, and the pain as VAS was really almost less than 1 in recovery room, and 2.1 at the 24 hours. Rescue analgesia, just only 2 patients received 1 dose of tramadol, and 1 patient received 1 dose of morphine 5 milligram. But these patients were because they refer pain of the bone graft iliac crest. Something we have observed is when there were iliac crest autologous graft, pain was we need to administer double doses of fentanyl if it was used iliac crest infiltration and comparing with a QLB2 group. Okay, it's almost double doses. And I think it's important not just show you a video so you can see. This is a patient with it was an fracture within this plate, but have iliac crest bone and the local infiltration by the side.
Vamos a ver. Ahora mueven la mano, abre y cierra los dedos. Perfecto. Presiona la muñeca, estira y el codo. Vale. Sube el codo, y ahora mueve un poquito la brazo. Vale, fantástico.
Okay. This is the same. It's with the iliac crest, but QLB.
Bueno, está grabado bien la clavícula, ¿verdad? Sí, ¿cómo se encuentra? ¿De gobierno? Nada. Nada. Muy bien. Vamos a ver. Estira los dedos, la mano. Sí, estira y cierra. Cierra, mueve la muñeca. Muy bien. Estira el brazo. Flexiona el codo. Muy bien, perfecto. Buenísimo.
Okay. And this is the other video. You show one of the patient and the consideration. Let me check. It's working. Yeah, that's working. And it was low doses of propofol, 4.3 into ICU. And at the end of the surgery,
el codo hacia arriba. Muy bien. Y ahora lo muevo un poquito más. Vale, fantástico.
well, this is the other one, and the sedation.
La cara. Manolo, ya te han puesto la placa, ¿vale?
Qué bien, qué bien.
Vale, pues enseguida.
Perfecto, ¿eh?
A ver, Manolo, abre y cierra los dedos. De la otra mano, de la otra. Vale, fenómeno, muy bien. Levanta el hombro. Muy bien, dolor.
Okay, so these are people we are working in this block, and thank you for your attention. This is from my hospital. It's a fantastic view here. This is Gibraltar, and in clear days you can see here. No, this is Gibraltar, and this is Africa. This is Morocco. So thank you for your attention.
Go to www.ultradissection.com or info@ultradissection.com.